Good afternoon, everyone, and welcome to Citywide Medical Grand Rounds today, which is June 12th, 2025. My name is Dr. Madeline Verhofstadt, and I'm the Chief of Medicine at St. Joe's, and we're pleased to be the host site for today. Bring up the next slide, please. And we'll bring up the next slide. So we'll start with a land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And we'll move on to the presenter's title slide. So this is a very special Medical Grand Rounds today. I don't know if this topic has ever been brought to Medical Grand Rounds. We always have an extremely interesting variety of topics and presenters, often largely focused on, the hard science of medicine, the clinical practice of medicine. I'm delighted to welcome our visiting presenters today. I had initially reached out to Keith about this maybe almost a whole year ago, thinking about how can we make sure to spread the word about what spiritual care does in our hospitals. And he was so lovely to agree to joining and providing this presentation and bringing in his colleagues from Hamilton Health Science. So our presentation today is Spiritual Care Practitioners, What It Takes, What It Gives. And I'm pleased to introduce you to the three folks who are here with us today. First off, Keith Metcalfe, who is a certified spiritual care practitioner through the Canadian Association for Spiritual Care, registered psychotherapist through the College of Registered Psychotherapists of Ontario, and he serves as the Director of Mission and Spiritual Care for the whole St. Joe's health system, so not just St. Joe's Hamilton. He also wanted to make sure everyone knows that he is a proud girl dad to two wonderful little ladies, aged 5 and 1 years old. So welcome, Keith. We also have Danielle Slump with us today, who is as well a certified spiritual care actually supervisor and educator through the Canadian Association of Spiritual Care, registered psychotherapist as well through the College of Registered Psychotherapists of Ontario. Danielle is a spiritual care clinician educator and professional practice lead for the St. Joe's Health System, and Danielle is the proud mother of 3 young children. And as well, we have Bob Tees, who is a certified spiritual care supervisor educator through the Canadian Association for Spiritual Care, registered psychotherapist, College of Registered Psychotherapists of Ontario, and currently holds the professional practice lead for spiritual care position at Hamilton Health Sciences. Bob has 2 adult children and 2 grandbabies. So very wonderful to have you all joining us, bringing your unique and important perspectives from the work that you do across St. Joe's Health System, and HHS, and helping to inform us all on the more medical clinical front lines about the work that you do so that we can provide holistic care to our patients. I'll hand it over to you, and I'll welcome everyone in the audience to consider any questions or discussion you might have for time at the end during Q&A.
All right, thank you very much. I want to start by actually just thanking all of you for taking the time and an interest today to be here for Medical Grand Rounds, and a special thank you to Dr. Madeline Verhofstadt for the invitation. It was about a year ago. We were sitting having I was having iced coffee, and that's where this got dreamt up, and really happy to be here. So a little bit today about our objectives. We'll start with a broad overview of the spiritual care profession and some working definitions connected to spirituality and compassion, and how these two come together at bedside through our models of training and professional practice. And kind of more of a subtle side from the objectives, we have some hopes as well. We hope to give you a better or an appreciation of spiritual care, the reason to provide us with a referral, some things around spiritual distress, and that you can entrust us with your patients. And these are your spiritual care practitioners, psycho-spiritual care providers, chaplains, we go by many names and titles. However, at the end of the day, we're all here to provide value to the patient care experience and work together on the interprofessional teams. We also hope to shed a little bit of light on our competencies so you can feel assured that when you're referring us, that your patients are in good hands and good hearts. And also hope that this presentation will have some takeaways for yourself that perhaps can be integrated into your own clinical practice. So first things first, what do we mean when we talk about spirituality? And I'm just going to go to the next slide. So we do have this working definition that a lot of us kind of lean into from Christina Petrowski, who is a palliative care physician, that spirituality is the aspect of humanity that refers to the ways individuals seek and express meaning and purpose, and the way they experience connectedness to the moment, to self, to other, to nature, significant and sacred. And to augment that just a little bit, I want to lean into the term vocation. When we think about spirituality in the workplace, we can think about, how do we find meaning and purpose in our work? How does that translate to retention? How does that translate to positive workplace experiences? So we like to include that and say that some of the things that we do is around staff support, and we really try to find and explore with our colleagues around meaning and purpose in their work. That is why we think spirituality matters in healthcare setting. Of course, these are the caring professions. These are the ones that are at bedside and finding meaning and connectedness with themselves and with the patients that we all collectively see together. So sorry, I don't want to get there yet. So anyways, the definition for spirituality we find to be quite all-encompassing. And when we care for the spirits of others, we explore what gives them meaning, and we look for what is sacred or extra special, and make the effort to build up the therapeutic alliance for those we provide care for. We are also very all-embracing of every individual and very passionate about advancing equity, diversity, and inclusion, and hold up the dignity of all. Ultimately, we do this to aim to provide a compassionate presence to those we encounter, and our team reflects this rich diversity in the region that we reside in. So let's talk a little bit about compassion. So I found this isn't quite working definitions of compassion, but rather a study done by Shane Sinclair. And if you haven't heard of him, I encourage you to look him up, who is a big name in the world of researching compassion. And in this study, they were looking at a group of palliative care patients and introducing them to what they considered to be an experience of sympathy, empathy, and compassion. And what they found was that the palliative care patients felt that sympathy was unwanted and kind of more of a pay-based response, kind of more just in the head. And empathy, they found, was an experience of feeling. You could feel the pain of the patient or the person in front of you. However, it didn't compel any further action. And that's where compassion comes in, where it kind of augments empathy in the sense of compelling you to act with kindness or altruism towards the person in front of you. For spiritual care practitioners, this means to be present in that moment with the patients or their families or staff or whoever we might be providing care towards. So to be very much present with them and let them know that they aren't alone. So on that slide, I do want to kind of put a little disclaimer out there that, as with any profession, spiritual care can be practiced with or without compassion. It's not like a default setting, but rather something that requires nurturing and cultivation. So I'll give you an example. I'll give you actually a couple examples. One from the kind of more of a religious take on spiritual practices, and another one that's more at bedside healthcare. So if a patient had requested, say, a minister to come in and provide a blessing or a prayer at bedside, and they came in and, perhaps waved the sign of the cross at the patient and, you know, acted with a certain function, but they were there physically, but weren't necessarily there mindfully or spiritually. They might be performing this function while at the same time thinking about whether the Oilers are going to win tonight or not. Similarly, with the spiritual care practitioner at bedside, you could go in there, a patient could be pouring out their whole heart and soul to you. They could be expressing all of the fear and anxieties that they're having within this experience. And you could technically even kind of validate the feeling or provide some level of support in that and say, like, yeah, I guess that can be difficult, just trust in the universe, it's all going to be okay. While still simultaneously thinking about whether the Oilers are going to pull it off tonight or not. However, what we try to do is really be present with them. So part of our education program is geared towards sifting through what might be underlying yourself. We do acknowledge that at bedside, these can be very uncomfortable situations. People could be sharing things that, make us feel a sense of countertransference or triggering something inside of ourselves that makes us want to go into our head and leave the situation, even though we're still physically present. So being compassionate does require work towards being truly present, and that's how we stay patient-centered in our caregiving processes. I like to call this meta-transactional, so that it's just kind of goes a step beyond a transaction of simply exchanging a couple words back and forth and some platitudes. To be truly present, to be comfortable in the uncomfortable, and to ultimately provide a compassionate presence and to suffer with those. That's literally what compassion means, to suffer with people. And that people really respond well, and they know when somebody is being truly present with them and when they're not. And you can use your imagination to go deeper into that. But at the end of the day, some of us might think, okay, well, we can do all of this. We can make ourselves presence, but who's got time for that? And what's been found is that it only takes about 40 seconds for a patient to feel that they've had an experience of compassion, that somebody heard them out. It wasn't necessarily just about the verbal. It could be that appropriate eye contact. It can be around holding the hand or putting a hand on somebody's shoulder gently and saying, I hear you. You're not alone in this. It could be expressions of that little hum as somebody speaks, to just say, I identify with that. I hear you out, and you're not alone in this. And we do all this mindful of our scope of practice and professional boundaries, and also ensure that we practice self-care routines to stay nourished without burning out from compassion fatigue, which is, of course, a major vulnerability for all of us who work in healthcare. So we will be moving shortly to Danielle, who's going to kind of take a deeper dive into this work and how we actually go about training an individual who's come with an academic background. Most of our folks either have a Master of Divinity or a Master of Arts in Psychotherapy or Spiritual Care, Master of Theological Studies, different programs. They could come already registered with the CRPO, or they may be pursuing that option, and definitely will be pursuing the option of getting accredited with the Canadian Association for Spiritual Care. The programming itself is a experience reflection in nature, and the learners and spiritual care residents, the spiritual care residents see patients, and they use their skill set that they've learned in universities and work with our wonderful educators who will provide them with clinical supervision, explore any of those hang-ups or those missed opportunities for further exploration or deflection, something we call spiritual bypassing, that may surface when they're describing their encounters with the patients. All of this is in support of the learners to work through their own triggers and countertransferences so they can be truly present at bedside and truly engage in the patient's story rather than in their kind of live within their own internal deliberations. Informally, we call this holding up a mirror for the learners. Formally, Danielle is going to get more into what it means to provide verbatim reports and interpersonal relationships and peer and individual supervision, all aimed at cultivating this compassionate presence that we bring to bedside. So on that note, I will hand things off to Danielle. Thank you very much, Danielle, for agreeing to share some anecdotes and a little deeper dive into our education program that we've all been through. Well, we've been through, the three of us. And it's a wonderful program. It's transformative. It's important, and it's definitely worth exploring and taking a deeper dive. So thank you, Danielle.
Thanks, Keith. So Keith gave us a very great broad outline of what our education is. So we are associated with the Canadian Association of Spiritual Care. Everyone that comes to us is connected to a university or seminary. Oftentimes people are doing this as part of a practicum. And so a little bit more about our education. So we provide individual supervision, we provide group supervision, we provide didactic work, different reading and writing, case studies, spiritual reflections, and verbatims. The verbatim is what I want to talk to you a little bit about with you, because it's a really unique opportunity where our students are invited to go and they have a visit, and then they come back and they write about it. So they'll write about what they said and what the other person said, maybe what they were observing within themselves. How were they feeling? What kind of things were going through their mind? What were they perceiving in the other person? And then they have some reflective questions after. And so what they're invited to do is to come back to group and to present that with the group, with the goal of reflecting more deeply on not only are they able to identify the interventions that they use, what different kinds of therapeutic modalities they were functioning out of, but like where were their own biases or assumptions or values coming up in the questions that they asked. Another part of that is also an opportunity to do a role play. So in that situation, the learner that went to visit the patient actually acts as the patient. So they try and embody that, and then their peers interact with them. So it's a different, like it's not a verbatim interaction, but it's a role play. So it's an opportunity for the learner to build this greater sense of empathy and awareness of what their patient might have been going through. One example I have of this is a learner that was supporting a psychiatric patient over the phone. And she really struggled, wondering, was she able to connect with this patient? She was struggling with the content. And so she brought this to her peers. And so what we did is we had the peers turn their chairs apart from each other so they couldn't see each other. And so they had this mock interaction. And for the learner, this was really transformative because she was able to identify this sense of compassion and connectedness, even though she wasn't able to see her peers. So this affirmed in her that, you know what, even though telephone isn't ideal, you know, we can still get a deeper sense of connection, and there is therapeutic value to that. She was also able to see her peers struggle through the content. So for this learner, it was a really deep normalizing experience that, you know, it's okay to have struggles. Everyone has struggles, and this is an opportunity to learn how to better engage. Another thing that our education really focuses on is this safe and effective use of self. The idea that we are what we bring, kind of like what Keith was saying. I mean, it's one thing to have this academic learning when like, oh, if someone says this, this is what I should say. But what we're really promoting is integration, this idea that you are the tool. And so an example of this is oftentimes learners will go to a code blue or a code pink and sit with this deep feeling of helplessness, and maybe even offer platitudes like, you know what, I'm sure your loved one will be okay, knowing that like we don't know. So that what we would do as supervisors or part of a peer group is we'd explore with this learner after what was going on inside of them. Was this bringing up a similar situation? Was it bringing up feelings of fear or anxiety and not knowing what to say, or maybe making things worse or not having the right answer? Maybe it's bringing up some beliefs that they have around death and dying, and those are impacting the care in the moment and their ability to be present. So therefore, we're encouraging learners to take their self and to integrate their skills, their knowledge, their interventions. So then when they go to this situation again, they're more able to be present. Another thing that this promotes is self-care, recognizing that we are impacted by the things that we see, by our patients. And not only is our goal to be present in the moment, so then we can respond from a place of authenticity and care, but then to also step away if we need to and care for ourselves and access resources that way. So Keith kind of alluded to this. Oftentimes at the end of our education, people do talk about it as a transformative experience because it's more than just the practical skills. We really are encouraging people to look deeper inside of themselves. That's what I have. Over to you, Bob.
Okay, thank you. Well, let me just say again what a delight it is to be at this education moment together. I'll talk a bit, maybe coming back to where we started, about the practice of spiritual care and what it looks like at the bedside or at the nurse's station. Spiritual care embraces a holistic approach to care, attending to the person's beliefs, values, behaviors, and experiences related to spirituality, religion, and culture. And spiritual care practitioners inspire hope, empower healing, make space for meaningful change. Spiritual care is practiced through the assessment and treatment of issues specific to each person. I often say we work with people of any faith, no faith, and ever in between. We've worked with families who are Indigenous, who are atheist, who are Muslim, who are Christian, who are not sure what I am. I just know I need to talk to somebody. And so the heart of it is to tune in, slow down, and to connect with people in terms of their unique story. Next slide, please. So here's 3 themes from our practice philosophy. And as I share these, a couple of stories from the bedside, just to acknowledge that this is tender material, and there's some traumatic moments and some situations. We're all in healthcare, I know we expect this, but just to be mindful of how it might touch you to hear some of the stories. Next slide, please. So of the 3 themes, first I'll say that helping people connect with the sacred dimension of their lives transforms their health experience. I'm currently working at McMaster Children's Hospital, but when I started with HHS a year ago, I was at Hamilton General. And I remember on the 6th floor in the trauma unit being with a young 20-year-old man and who's originally from India, had come to Canada for his education, but got in a motor vehicle accident, single car accident, hit a guardrail and lost his leg. So parents flew in from India to be at the bedside. Fortunately, spine and brain were fine, but what a tragic loss for a young, otherwise healthy 20-year-old man. And so along with the loss of limb, there was questions about he was facing what his meaning of his life. Who am I now without a leg? And what about my faith? And so there were some of the Hindu images and texts in the room of the hospital room. And he was very explicitly said to me, I need to talk to somebody about my spirituality, because I don't know how I'm going to get through this. So, and we were able to just acknowledge that disclosure and realize that while this is a loss that entailed some grief, there was also an invitation somewhere in this crisis, and not to put sugarcoating on it or anything like that, but that he was acknowledging he was facing questions of what kind of life was I living that got me into this reckless moment, and what kind of life do I want to have now that I've lost so much, I've kept so much. How am I going to start walking, literally again, walking with one leg, but also figuratively in terms of his life journey? And so I was very appreciative of our conversations. Often he would ask me for advice, what I would do or what he should do. But I was, when we were asked for advice, more inclined to say, well, tell me a bit more about what's been on your mind. You know, is there anything that's being spoken to you or that you're sensing? Not that we wouldn't give some sort of guidance or resources, but often people already have within them this sort of knowledge, or what are you hearing in your conversations with your parents? What's coming to mind? And one of the phrases he came is, I need to slow down. And I need to take time, take each step in its own time, but also to find where maybe God, in his religious understanding, is teaching me somehow through this. And so it was a very beautiful moment. I also say now I'm working at the Children's Hospital. There's other moments of these tenderness of loss, often with pregnancy loss and the labor and delivery, and sometimes in pediatrics where there's a loss, where people want some kind of a blessing or some kind of a conversation of grief support. I've been very moved. I've been in the field for 25 years, but new to a children's hospital. And so the blessings for the tiny little patients that love and peace and strength would hold them, carry them, is to be in those tender moments where there's so many tears, even with in one situation where there was a baptism desired, and that the tears and the holy water mingled together in a way. And I think that's again where the sacred dimension is transformative. People, when I did the baptism with a little 11-month-old, I'll never forget how the parents said, at least we had that. That was now something that they had as part of their spiritual story. And I'll talk about story a bit later on. So those are a couple anecdotes from the bedside where, again, helping connect with the sacred dimension can transform the health experience, make it more than a crisis, and bring the larger questions of meaning. And I'll say too, the hard questions too, like sometimes people can have a deeper sense of their spiritual awareness, but otherwise there's a profound spiritual distress. All it is pain and noise. Nothing makes sense, and words and concepts have no meaning. So a lot of the time, the best thing a spiritual care practitioner can do is be silent and to be there and just acknowledge this. My heart breaks that this is happening for you, but I'm here with you, and their team is here with you through this time. Next slide, please. The second theme in practice philosophy, creating therapeutic space for an existential shift, opens the way for clarity and peace. And here I'll talk a bit about staff support, as well as care for patients and families. Often the spiritual care practitioner will care with staff in different ways. Sometimes at HHS, we even have a model of psychological first aid if staff need a listening ear because they were at a traumatic situation and they need to kind of take some deep breaths and unwind. I remember at HGH, one of our non-clinical staff had a panic attack, and so I responded to the code blue, and then ended up in the emergency room in a quiet little nook having a half-hour conversation as she just needed to unpack some of her story, and you could feel the stress decrease as she just had a chance to share a bit of her story. At St. Peter's, I worked there for a few months, and the group of outpatient geriatric staff we're having some stress organizationally, personally, and clinically, and they thought, oh, we need something. We're not sure if we need an exorcism or whatever we need, but we'd like to talk. So we made a deal where we talked for a half hour a month, and we had a group of stones. People could pick a stone from the beach and just share a bit about what's going on for them, had some poetry and music and a blessing, and we'll do that blessing at the end of our presentation today, a blessing for health practitioners. And I must say that half-hour space of just being able to connect in a spiritual, not religious moment turned out to be very grounding and nourishing for the staff. Also at Hamilton Health Sciences, we have the blessing of hands or honoring of hands for Nurses Week, where we go to nurses and allied health, any staff throughout the hospital and do a brief moment of pouring water over hands and saying, we honor these hands, hands that bring healing, hands that bring health, hands that bring compassion and hope. And it's a very hygienic ritual. You just pour the water over the hands and into the thing, so as there's no contact precautions concerns too much. But how meaningful it has been for when we did this just back in May 12th to 16th, for staff to receive this acknowledgement of their work and care. It was such a positive impact that now when we do our role presentation at health professional orientation, at the end we do offer honoring of hands for the new staff. And that's been interesting about how many people want to take that up. So there's the existential shift, I mean, is that there's something about, wow, yes, who I am as a person is honored and valued in the work that I do. And then the honoring of hands, we say, may you be renewed and strengthened in all that you are and in all that you do. I would say also in staff care, bereavement support has been something that we've been called into often over the years. And it's heartbreaking that's part of our work, but sometimes because we're known, people don't necessarily maybe not have a faith leader, or they do, or they don't have anything, but they need something sacred, some sort of practice, because there's been a loss, whether it's been a staff loss or a staff death that's happened. We've even done memorial student services in the hospital for staff because staff needed a chance to debrief their grief and loss experience, and sometimes a very simple ritual to bless the life of the person, to share about the meaning, and to realize this life we've lost has been held. At Stone Church Family Practice, once a year, all the physicians in Stone Church will have a memorial service for patients on their caseload who have died. And I've been sort of the de facto spiritual care practitioner the last few years for that. And it's very meaningful to hear physicians go through a list. Some people get a few minutes of conversation. Sometimes you just go through the list. And at the end, again, we hold a blessing and have some music to acknowledge the grief experience of healthcare practitioners. So whether it's grief and loss, or like where we honor the hurt we have that we carry, or whether it's honoring of hands or celebrating, there's different ways that the spiritual care, existential care can weave into staff well-being and staff experience. And the next slide, please. I'm kind of going quickly because we really want to leave lots of time for comments and questions from the group. But our third practice theme, I'll say, is caring for the story empowers a healing journey. Maya Angelou, the poet, said, "There is no greater agony than bearing an untold story inside you." And listening to stories is a large part of what we do. There's a bit of a stereotype that our work is, oh, it's only for the religious, or, oh, I'll call the pastor, or I thought they might want to talk to you, but they weren't religious. Whereas actually we connect with everybody in their story, whoever they are, and sometimes unspoken questions of meaning arise in the conversation. So I love that quote from Maya Angelou, and I like to highlight the counseling aspect that we bring to the bedside as well. This photograph has a rose in a styrofoam cup, not the most elegant vase in the world, but you can see in this picture, there's the uneaten food in the food tray, the tissues, the sharps container in the background, some other junk on the tray. This is the emergency room of Niagara Falls, a personal story where my mom was hospitalized for a period of time, and my mother was a florist. And so to her to have a rose in the midst of 7 days in the emergency unit, if you can believe it, before she was transferred to another part of the hospital. This rose was part of symbolize who she is, not just a patient, not just someone wearing the weird blue gown, but the person that she is. And actually, one of my former students became her spiritual care provider during that time. So it's very interesting to see this intersections of lives there too. But I think the rose is a powerful symbol, like a blossom in the barren wasteland that sometimes healthcare feels like, where we lose so much and we don't feel ourselves. We're so uprooted from home. Yet to know a person's symbols. I'll share us one final story. I worked for several months with a man who knew he was coming to the end of his life, and he was a survivor of religious trauma and personal trauma, and really wanted to come to the end of his life with some sense of that he's not going to hell, as his earlier religious context suggested he might what will happen to him, and also to be able to have peace with his family, which he did achieve, but also he had some deep anxieties about death and death anxiety that anyone might have. And so as we made space to share his story, he shared his story. He did disclose some of his religious trauma, where there was sexual abuse in the past that put him away from the church for the rest of his life. And he needed someone like myself, someone who had a spiritual vocation to hear and hold space for that. But as we told the story, also, he shared with his family present some of his childhood losses of other young children in the family who died, and how that was traumatizing for him. And that was impacting his lens through which he was seeing his own death. And these stories were new news to his family. So it's quite remarkable, isn't it? How, again, this greater agony of bearing an untold story inside you, and the profound relief he had, and his family felt relief too, that now they could join him. One of the practical things they did is they brought photos of his parents and photos of family members into the hospital room. So those people could be present to him in a different way. And that was profoundly consoling for him as he planned his end-of-life journey. The metaphor we had was the garden. So going back to the flowers, we acknowledge that his life is like a garden. There's blossoms in it, trees, good things that have grown in his life, a beautiful and fruitful life. Yet there were also some thorns and weeds in that garden, and there was even some toxic pollutants that had been put there. And he needed to talk about the pollutants and the thorns, just to acknowledge them, but he didn't want to talk about it in an extended therapeutic way. He just needed to acknowledge they were there, because he said, I really want to focus on what I'm happy about. And so we talked about, again, the gifts of his life, the life review, and the metaphor of the garden became a way to contain both the painful things and the beautiful things, the tragic things and the delightful things that were part of his journey. And we even wrote a song together about, being in the garden. I come to this garden alone, kind of a riff on the classic hymn, and that became a recurring metaphor, and it allowed him to maybe take a bit more ownership of his story. Because you just can't, just focus on all the blossoms when the thorns are getting you, right? Or be so cut by the thorns you forget the blossoms. The garden metaphor could contain all of his experience, and he could play with that and share what he needed to share in our conversation. So those three themes, about staff care, about some other bedside care, the place of counseling, the place of ceremony, and this life review story, I give a bit of a window into some of our actual practice at the bedside. So I'll pause there, and I think we're back to Danielle.
Oh, thank you, Bob, for those stories. I think that paints a really fulsome and beautiful picture of some of the work that we do. And so you'll see on the slide that we have a list of common supports that we offer. I mean, Bob has alluded to some of these. And before maybe I provide some examples, I just wanted to reaffirm to the team that, we are part of the healthcare team. And so we do charge, referrals can be made. And so part of what we can do is walk alongside you, especially if you are having difficult conversations with patients or families. I remember being called at 2:30 in the morning from a medical resident that had a trauma come in, and they had to tell a family that their loved one didn't make it, and they'd never done that before. And so for them to know that spiritual care was available, even in the middle of the night, to call and to join them, to offer some support to the family, because they were a little bit anxious about that. I also worked at the trauma hospital, and regularly, if there was a trauma, the physician would call and ask for spiritual care, just to join them, maybe to support the families after, if they needed to leave. So just know that we are available to walk alongside with you as well. And so kind of to flesh out some of these supports that we offer a little bit more. So we offer this compassionate and supportive presence in times of stress, transition, and loss. So oftentimes, people come and they've lived their life in a certain way with a certain set of beliefs and assumptions. If I eat right, if I exercise, if I meditate, then these bad things are going to happen. And then something happens and they end up in hospital, and the way that they saw life before no longer fits. Maybe they're asking questions of like, why me? Where is God in this? And so that is where we can come and walk alongside them, exploring those questions, not giving them answers, but inviting them to reflect on their own values and beliefs, and maybe just sit in the muck, in the brokenness, and the darkness with them. Oftentimes people, they come in and it's a time of grief, whether it's withdrawal of treatment, anticipatory loss, maybe someone's thinking about their own deaths. And if someone's religious, what we can do is we can connect them with their faith community, or we can support them in a ritual. But I often find that it's those people that don't necessarily have religious beliefs or rituals that really struggle with, what does it mean to say goodbye to my loved one? And that's where we can step in. Just a couple examples, had a young individual that came into another hospital with a pretty significant trauma and then were transferred. And so I met with this individual's parents, and his dad used to go to the bar at the end of their street and sing karaoke with his son. And so for him, as they were withdrawing treatment on their son, he brought in the CD of the favorite songs that him and his son would sing, and he sang to his son. And how meaningful it was to do something that they did together at the end of his life. I once also had a woman that was in the hospital, and she was dying and unconscious. And so she had struggled with mental health most of her life and addictions, and had pushed her family away. And her mom and her sisters came in and they said, you know what? She never let us love her when she was alive, but we're going to do it now. So they would bring in a thermos of wine, and they would set up and they would watch rom-coms and drink wine in bed with her. And for them, it was just an opportunity to love on their family, even though they couldn't do that when she was with them. Another example, supported a burn victim that had the burns were a result of self-harm, and spending time with them, identifying that the wounds now on the outside of their body was really a representation of the brokenness in the wounds internally. And so as these wounds were being cared for by staff, we could explore what it looked like for her to care for her internal wounds. And so with her, what a privilege it was to actually bring her outside for the first time and to walk with her what it was like to be outside, to have these wounds exposed to the world and still be okay. and to know what it was like to accept and be accepted by others, even in her brokenness. And also part of what we do is legacy work, especially around those individuals choosing medical assistance in dying. There often is a period of time of waiting, and people don't know what to do at that time. So it's an opportunity for spiritual care to come in and to talk about, what does it look like to me to live well in this moment? What does it look like to leave a meaningful legacy for my family and friends? Another thing that we do that Bob alluded to is this providing prayer and rituals, whether it be at the loss of a life, through a baptism or a blessing. Many of us have been called before to do a blessing before amputations, and some of those creative rituals to support individuals as they think about grief and loss, and bringing a sense of creativity. So that is my brief list of some of the supports that we offer. And we bring a lot of creativity, a lot of compassion, and love working collaboratively with you and the other parts of the healthcare team. I alluded to this a little bit. Just making referral. We all work on systems with electronic charting. So referrals can be made through there. You can go through paging. You can go through switchboard. We are available. Oftentimes, people will ask if they need to ask the patient gain consent before referring spiritual care, and just want to reassure you that we always gain consent. But sometimes when people, they hear the words chaplain or spiritual care, they maybe have this particular image in mind that doesn't necessarily represent what we offer. So sometimes it's okay just to say, hey, Danielle, Bob, I know this person's going to receive a pretty devastating diagnosis. Can you just check in with them? And we would go in and we would introduce ourselves and our scope of practice, gain consent from them at that time. So let's move on to questions. Or don't all speak at once.
Thank you so much, Danielle, Keith, Bob, for giving us this fantastic primer on the important work that you and your colleagues do in this space that really transcends departments of the hospital. And you've shared some very moving examples of where spiritual care, clinical scenarios where spiritual care can help support people in their journey. So I have a few questions, but I don't want to hog the microphone. So I will invite folks in the audience to please enter any questions that you have in the chat or the Q&A, or if anyone would like an opportunity to unmute and share your question, just to speak it out loud, just raise a hand and we can unmute you. So I will come first then to a question from it looks like Dr. Dorsami, so I'll read out loud, or maybe it's a comment. One of the profound spiritual questions at end of life I've learned from a lecture by a prominent and world-renowned critical care physician from Rush University in Chicago was asking the question, are you at peace with yourself? Really interesting, and I wonder I'll maybe offer that up for our presenters to offer any reflections and maybe share as well any questions that you each find very important in those conversations in a similar situation.
Maybe I'll say, I love that question also. I think a few things that brings to mind that are you at peace with yourself? There's the question of language is so important, right? It's so personal to eat. And I think, hospital spiritual care was born in the tradition of Christian pastoral care, like 100 years ago. And, when a lot of ministers noticed that they were no good at talking to people with problems. They were good at books and teaching things. And so the whole idea was to immerse people who were training for Christian ministry in hospital work, so you could get out of your heads and into what's called the living human document of the messiness of life. What are you going to say about the meaning of life when you're with someone who's suffering. But while the origin was in Christian pastoral care, it's grown quite a bit. We're now part of the Canadian Association for Spiritual Care. It's a multi-faith organization, again, working with people of all culture and religious perspectives. And I think we've tried to, be mindful where a religious context can be very nourishing for people. And it's also been very harmful or toxic for other people. Sometimes in the same hour, you'll talk with two people from radically different viewpoints. So I love this. Are you at peace with yourself? Words like peace, hope, life, where do you find strength? Gratitude. When you think about your life, are there certain things you're thankful for you'd like to tell me about? I mean, I think there's some universal kind of language that have a underlying sacred or meaning of things. Hope, peace, love, courage, choice, freedom. Viktor Frankl, who a survivor of Auschwitz, in his book, Humankind's Search for Meaning, said we can lose everything except the last human freedom, which is the freedom to choose how I'll respond to my circumstances. So things like, freedom, peace, they give a common language. And as much as possible, I think it's nice to find, this is a long answer, common language that helps people. And what are people's own language that they're giving us sometimes? So it's a very simple question with opportunity for people to go where they want to go.
Thank you very much, Bob. Anything further to add, Danielle or Keith? If not, that's a-okay. So I've got a question to build on something that's been sprinkled through the presentation and was even there in Bob's reflections. Many of us, when we came through training or earlier in our careers, would have been more familiar with a different model or even language around spiritual care, and more referring to chaplains, or, where it was more, perhaps especially at a faith-based institution like St. Joe's, where it was assumed that this was going to be a priest or someone from, even more specifically, a Catholic faith background. Wondering if you could, obviously, there's probably a very interesting history about all of this, but I wonder if you could help us understand when did that really seem to change? And alongside that, you've mentioned you've got folks from various faith backgrounds on the spiritual care staff. How does that play into, like, is there, are there active efforts to try to matchmake patients with someone who comes from a similar faith background, or is it really meant to be each person meant to be coming with a very multi-purpose lens? And how does that play out at the bedside?
I'm happy to start the answer. This is a great question, Dr. Verhofstadt. Thank you for asking it. And yes, so acknowledging that as in my role as director of mission and spiritual care for the St. Joseph system, a very faith-based organization kind of founded by the Sisters of St. Joseph, I would say that at its core, we are a values-based organization. So right from the very beginning, that when the sisters founded healthcare and wanting to meet the unmet needs in their community, this is dating back to the 1600s, it was always to do so in a way that was without distinction. So they really tried to emphasize that we care for everybody, mind, body, and spirit. And yes, if you thought about it into kind of the modern era, when the spiritual care itself as a profession may have seemed this archetype of the priest is going to come to the bedside or something along those lines. And as society kind of transforms, so to the profession, like, we have to meet the needs, and what are the needs, and who are the people, who's coming through. And when I was speaking earlier about our passion towards equity, diversity, and inclusion, we want to include everyone. We want everyone from different perspectives to come in, because they add value to our department, to our profession, lived experiences across many different identities and spiritualities, and lack of spirituality in the general sense. We have atheists that practice spiritual care on our teams. And so, to answer the second part of your question around, do we make a conscious effort to interface or to put in front of somebody at bedside someone who might have a similar We will. Part of that is maybe coordinating with community clergy if need be, with folks out in the community to invite them into a patient's care experience. However, like I said, we do have a lot of people on our team from many different backgrounds, all walks of life. We're very proud of that, to keep moving in a direction of inclusivity and bringing people in. There's been strides in the last number of years around that assurance. So hypothetically, anecdotally rather, if we did have a patient who was of a Muslim background, and if we have a Muslim spiritual care practitioner on staff, and we do, we might try to match them up to provide a specific form of spiritual care for that individual to help meet that specific need. And we do have like a Catholic priest, so that still is the case at St. Joe's, especially. We have one on staff, but I will say that even that individual is a certified member of our professional association, has went through the same amount of post-grad training, we'll say, and is also a member of the CRPO. So he does go and make his way around to see everybody. However, when there's a specific need for a Catholic patient, we will make that referral and send him in. And that could be the case with whoever we have on staff. If it looks like there might be somebody who's a better fit, we will do our best to help support the patient in ways that others may not be able to.
Can I jump in there too, Keith?
Yeah, sure.
Thanks. Great answer. I also wanted to say that in our education program, we try and get as many people from different backgrounds and cultures. So then the idea is, if I'm sitting in this circle and I was Christian and say someone else was Christian, it's an opportunity to reflect like, oh, this means two very different things. We live this very differently. We might have some common values, but the way that we live out this looks different. And so the hope is that we're building this awareness that when I see that someone is Muslim, I don't come with an assumption of I know what that means for that person, right? If I see someone of no faith, I don't make the assumptions that I know what their beliefs are. So really what we're training people to do, and what we try as spiritual care, is to go in and to let this person teach us what their faith means to them, what their culture means to them, and how that is supporting or maybe like causing harm to them at this time, and how we can support them. So yes, there are times when we try and pair up people from specific religions, but also recognizing that, like, you know what, it might be my own assumption that this person that looks different than me or has a different religious belief doesn't want to talk to me. And that might not be true. So really coming from a place of curiosity and openness, and providing accommodation if that is required as well.
Yeah, exactly. I mean, at the end of the day, we do train our practitioners to be able to provide the same level and high quality care as if anybody else. So you can have confidence in that no matter who's on their way to bedside when you make the referral, someone is coming that's had this training.
Maybe just a couple quick to finish this one. One is just practically the Canadian Association of Spiritual Care changed its name in 2011 from the Canadian Association for Pastoral Practice and Education to the Canadian Association for Spiritual Care. Thought about Canadian Association for Spiritual Health, but CASH seemed maybe not the best acronym. But that was a historic change. But that moving towards that name change, obviously there's quite an evolution. I see it sometimes as the circle of pastoral care morphed into a collage of circles, all making Venn diagrams. And within those Venn diagrams, there's some common points of connecting people where they're at and assessing their personal spiritual needs. But sometimes, like you may connect with someone's belief world quite well, and you would be their direct provider. Sometimes if you don't connect, you can still provide support, but facilitate via referral other kinds of cultures. And so navigating that complex collage of the overlapping pieces of the Venn diagrams is now what our modality is, which makes it a bit harder to understand if you have the older paradigm in mind. And we're trying to find new ways. I think the Venn diagram model helps me a little bit to see where there's commonality and universality playing together with each other. Yeah.
Fantastic. Thank you all so much. I imagine, as in other areas of the hospital, you could always use more resources and more staff. If you got a big influx of increased referrals following, education outreach like this, is the team large and nimble enough to accommodate, or how are things going from a staffing standpoint? And then I'll turn it to Dr. Tallman, who's got a hand raised.
Let me just say, it'll be all hands on deck. We will navigate, we do our own triaging too. So there is, what is the level of urgency, and we will just take things from there, but I appreciate that comment.
Excellent. I know that's always a tricky one. Actually, there was a hand up, but it looks like Dr. Tallman may have may not be on the meeting anymore. So I think then we will turn our attention to wrapping things up. And it's too bad we're not all in person, because we could all give you a great big round of applause. So thank you again, Keith, Danielle, and Bob, for joining us today and for all the work that you do. I think there are increased opportunities for us to bridge that gap and ensure in our Department of Medicine that we're being very holistic and considering the patient's spiritual care needs alongside their kind of medical diagnosis and treatment as well. So this is a great opportunity for us to better understand what it is you do and the resources that are available for patients across both organizations. So thank you so much. And I'll thank everyone for attending today. And participating. Thank you to Kathy Vermelt for organizing. And I'll invite everyone back for medical grand rounds next week. June 19th is Dr. Jess Yee from Thrombosis with HHS as the host site. So thank you all so much and have a wonderful day.
I wonder if we have just the last minute for the blessing in the final slide. Do we have
my goodness, I apologize. That's
no,
wonderful.
nothing.
Anybody that hasn't logged off, stick around for a blessing.
Okay, so, well, thank you all. A blessing for health practitioners. And so may there be grace for all our friends and relations, the complicated and often wonderful web of the ones we love and who love us. And may there be wisdom and clarity for us for the struggles of system navigation. May there be light on matters of justice, process, effective care, and support for teams. May circles of light surround each patient and family interaction. Amidst our expertise and interventions, may something extra come, some action of grace to shine and strengthen and make ways forward. And for our personal journeys, may there be, for each of you, may there be health and rest, play and purpose, and opportunities to come home to your unique, infinite, precious value as a unique person in the world. May healing and renewing waves of peace and love wash over us. So peace to you all.
Thank you for those beautiful words, and sending us off into our day. We had to wrap things up, but Dr. Tallman reemerged. So maybe we'll, of course, some folks may need to run, but seeing as she's still here, I wonder if maybe one or more of you might want to reflect on. I wondered if there is concern regarding the increase in algorithmic-based care and how this might affect patient care. Anything that any of you have noticed or participated in discussions related to this?
I'm concerned as HHS is going through an exercise that however they capture data about patient experience and well-being, that whatever lenses are used, I hope are adequate to capture what is a very difficult to quantify and sometimes difficult to communicate modality of care that is a determinant of health, but perhaps not, it's not going to compute. So I carry some concern and some curiosity about what that might look like.
Yeah. Mm-hmm. Thank you. Thank you.
Yep.
So big topics. And Marianne, I'll encourage you to continue that conversation with Bob and others over at HHS. It sounds like many people tuned in to just making sure that we're really focusing on the right things when it comes to care and patient outcomes and experience. So thank you for rejoining the feed Marianne, and for sharing that question. And thanks again to our presenters. Have a
Thank you.
wonderful day
Thank you.
and a wonderful
Wonderful
week,
day.
everyone.
It's been a delight. Thanks.
Thank you so much.